Hello, my name's Susie Stanway. I'm a medical oncologist, and it's really super to be in Cape Town for the 10th Global Cardio-Oncology Summit. We held this meeting in London in 2017, and it's really brilliant to see how, as a field, this has really blossomed, and how many more delegates we have at the meeting here this week. So it really hit me coming out of the airport in Cape Town. South Africa currently have the presidency of the G20, and the G20 leaders are about to come to South Africa in a couple of weeks' time. And the words solidarity, equity, sustainability being really the theme of this G20 meeting, really ringing true and being so pertinent to global cancer control. So cardiovascular disease is the biggest cause of death around the world. And deaths from ischemic heart disease are roughly the same as deaths from cancer, which is the number 2 cause of death. So it's estimated that in 2050, there are going to be 18 million deaths globally from cancer. And yet we know incidence to mortality ratios are not the same within our countries or between our countries. And so there's a lot of work to be done. I think during my talk, I really tried to focus on what's going to really make a difference to improving cancer outcomes with respect to focusing on prevention. Recent Global Burden of Disease study showed that around 41% of cancers around the world have modifiable risk factors. And we know what needs to be done. There are WHO best buys. There's plenty of data with focuses on cancers such as cervical cancer and HPV vaccination and the 3 pillars of the WHO initiative. Fiscal policies to protect people around smoking. We know that around 80% of the world's smokers live in low and middle income countries. And the list goes on. We know that we need to be focusing on early diagnosis, early presentation, and that we need to be focusing on access to cancer care across the continuum. This needs to focus on system strengthening. There needs to be workforce development. We know the huge shortfall in workforce there is globally. And this really needs to have an emphasis on disciplines such as nursing, who are the largest subgroup of the health workforce. And also on developing cancer intelligence so that we've got data that's going to inform policy making and is going to help us around the world be able to develop our services. But I think most importantly, there needs to be political will. We need to make sure that we as healthcare professionals are speaking the right language to the right people and that we engage with politicians and civil servants. We need to also make sure that we address social, cultural, political commercial determinants of health, etc. And health literacy has been identified in so many studies as being one of the biggest barriers to improving health outcomes. Cancer care, importantly, really needs to be embedded within universal health coverage. And I think it's important to stress that universal health coverage is possible, even when it seems like we're in challenging times. And just looking at Thailand, for example, which implemented universal health coverage off the back of the 1997 financial crisis, and the NHS, which implemented the NHS off the back of the Second World War. So it can be done. I think the elephant in the room is how this is all going to be financed by countries around the world. Global debt is now at an all-time high of $8.8 trillion in lower middle income countries. But yet we know the loss to the economy from non-communicable diseases is also huge. It'll be around $2 trillion per year from non-communicable diseases. And so I think we need to be learning from each other. Health systems are financed in different ways around the world, whether it's publicly financed from social mechanisms or from taxation, privately funded or blended finance, or other mechanisms. And so we all need to learn from each other and come up with innovative ways that this is going to happen to ensure equity of access. I kind of touched upon in my talk that how we're living in this turbulent, fragmented yet interconnected world with so many other existential threats, all of which impact on our ability to deliver non-communicable diseases, whether it's conflict in its many forms, which are now becoming more international, more protracted, more complex, more multidimensional, and causing really terrifying numbers of people to be forcibly displaced. Over 120 million people around the world are forcibly displaced. 1 in 4 people in the world now live in countries affected by conflict. And how are we going to deliver non-communicable disease care to people in these settings is of paramount importance. Pandemic pandemics. We saw 10 million people around the world died of COVID-19. It exposed the fragility of all of our health systems. And how do we adequately prepare ourselves and develop resilient systems to withstand shocks such as these? And multilateral organisations such as the WHO have got toolkits that can help our countries do this. And then also artificial intelligence, digital technologies. Roland Dilling, who is their medical lead at AWS, gave a fantastic talk on what this is going to look like in the future. And we've got the recently published WHO toolkit on implementing on safe implementation of digital technologies and how this needs to be considered within global health. And then we've got the climate change and how this is going to impact last year's report from the UN on new human security threats in the time of the Anthropocene really highlighted this. And I think other domains such as justice needs to be factored into this. And then off the back of these sort of four main existential threats and how these interfere with ability to deliver non-communicable disease care, we've got other broader intersections such as changing demographics, urbanisation of populations, ageing populations, moving populations. We've got raging inequalities around the world. We've got markets, market volatility. We've got debt, as I've already mentioned, inflation. And now more than ever, we really, really need to have good leadership at national and international levels. So I really finish my talk by quoting from a recent Lancet editorial that really I think we need to shift our thinking from despondency to optimism. And we need to present this equity of access to non-communicable disease care as an ethical imperative and an economic imperative. So you couldn't but leave GCOS this year optimistic. Despite the burden of disease and the challenges that have been described during this meeting, the global cardio-oncology community has come together and highlighted advances and collaborations. From the edifying opening from Alexia Oliver about humbly sharing her lived experience to the session on cardio-oncology, where we heard from clinicians from Accra, from Algiers, from Durban and from Mombasa, the future is bright.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.